spinal cord. Now the spinal nerves coming off. We already talked about 8 spinal for cervical, 12 pairs of thoracic, 5 pairs of lumbar, and 5 pairs of sacral. There's a coccygeal, but we won't talk about it. Here's a cool picture. Vertebrae are actually numbered here. We know that the spinal nerve is actually the part out here. It's where we have our motor and sensory are combined. So the spinal nerve is once it has left the confines of the vertebral column, and you should know that they're known as mixed. So the dorsal and ventral are combined, and once they're combined, they become the spinal nerve that's a mixed nerve. So the spinal nerves that come off of here and go out to the body have connective tissue layers. The connective tissue layers are almost exactly like the muscle tissue layers that we had to learn. There is the epineurium. We can see the term neurium. You guys remember muscle was mysium. Epineurium is going to go around the whole darn thing, the whole entire nerve. Perineurium is really just going around bundles or groups of axons inside the nerve. Endoneurium is only going to go around a single neuron. So dermatomes are areas of our skin that a specific nerve will innervate. Sensory information is going to come back, but it actually comes back from a very specific strip of skin. On this picture, we can see here where the dotted lines are, you can see this strip of skin. It actually coordinates over here in the numbering. So if you were to poke a needle onto somebody, you know, near their belly button, and your person can feel it, you're like, all right, T10 is working. You know, like if you're worried about having someone having sensory impulse where they may have spinal cord damage, anything from that damage point up. So these are areas that literally have information coming back to a very specific spinal nerve coming off of the spinal column. So those are known as dermatomes, but they're sensory and they're strips of skin. And so they're sort of branched to the body a little bit different through embryological development, but those are the regions. So the L3 that's coming off of here is really going to be the area sensory serving like near your kneecap or the lower end of your quadricep. Beyond that, so this is now, we're now into the nerves. Remember we talked about the cervical enlargements and the lumbar enlargements. We have what's known as a plexus, and a plexus is like a net or a network. And really we have spinal nerves coming off, but because we have a whole bunch that have to go out and control so many individual muscles, that we actually form a network. Cervical plexus is using these specific spinal nerves. So C1 through C5 are going to get grouped together and make this plexus. The brachial plexus, it's using, also shares C5, but it also uses C5, C6, C7, C8, and T1, the first one. And they all branch to be this brachial plexus. That's going to come through your shoulder. Then we have no plexus through the thoracics. It just, nerves just go out and go to where they need to go. There's nothing extra. There's just so much more of the limbs coming off the nerve that we have to create these plexuses for our limbs. So there's not a plexus for the thoracic. Down here, the lumbar, you start from T12, L1, L2, L3, and L4 is going to be this lumbar plexus that's going to serve part of our legs. We have between our lumbar and sacral plexus, we have our genital area as well as our lower limbs. Our sacral plexus is going to be here, L4 through S4. You will need to know the plexus names and the nerve root that plexus comes from. Those are the ones that come off of here. So if we were to count 1, 2, 3, 4, 5, these 5 kind of come together to form a plexus. Then we have 5, 6, 7, 8, 9, and T1. These guys are going to come together to form the brachial plexus. We have no plexus until we get down to the last of the thoracic, so T12, L1, L2, L3, and L4, they're going to come together to be the lumbar and so on. So these are the roots that we're talking about. Cervical plexus. Cervical plexus, what are the roots from it again? C1 through C5. What you're going to need to know is the plexus name, the spinal nerves that make it up, and then you're going to need to know the major nerves that are coming out from there that goes to the body. The one that you need to know for the cervical plexus is going to be the phrenic nerve, and the abbreviation for nerve is just a lowercase n with a period. The phrenic nerve serves your diaphragm, and so that's what's going to control your breathing. It makes lots of other nerves. It's just the phrenic one that I want you to know is the main one that you need to be responsible for from the cervical plexus. There's loads of others. I just have you know the phrenic. Even though C1 through 5 is all of the cervical plexus, the phrenic nerve specifically has fibers originating from 3, 4, and 5. So the expression or the little rhyme, 3, 4, and 5 help keep you alive, is if you break your spinal cord and you're above 3, 4, and 5, you're not going to be breathing long enough to survive. So that would be a death. So if you have a spinal cord injury and you're within 3, 4, and 5, you're going to need breathing assistance. If you're below 5, and you're still going to be paralyzed, but you could breathe on your own. So that's where that expression comes. But I want you to know the cervical plexus is all of C1 through 5. The phrenic nerve just happens to, it personally originates only from those ones, and that's where that expression comes from. The brachial plexus is our hard one of these because there are 5 nerves you need to know that come off of it. You will need to know for your practical exams, that's why I started this pattern on the board. You'll need to know the plexus name, the spinal nerves that it serves, main nerves, and what they do. Diaphragm, breathing. You have the brachial plexus and the nerves. So you should know for the brachial plexus, what are the spinal nerves that serve it? C5 through T1. And the nerves that come off of the brachial plexus, we're going to start with the first one being the axillary nerve. Axillary nerve is really, remember axilla means your armpit, and it's going to be to your armpit, this region. So the main thing that you're going to need to know for the axillary nerve is, say, your deltoid muscle, and even though we haven't done the muscles yet in this class, we put the bones and muscles at the very end. The deltoid is your shoulder muscle, so it's the one that's going to lift your arm straight out. So we'll say deltoid, and that movement is known as abduct. It's like you're taking your arm away, abducting it from your body. It means abduct your arm. But for where we're at now, let's just call this shoulder. So all the nerves that we see coming down this arm, we have the axillary that's going to branch off up higher up, and it's going to go to the shoulder area. Then we go to a musculocutaneous, and then we're going to go to the radial and ulnar. So notice this. The pink region in this diagram is going to be identified by the axillary nerve. That's why I have it colored that way. So the axillary really means pink. So it's showing you the anterior hand. It's saying this pink region is your shoulder. Axillary is going to serve there. It's up here. So we have a radial is next on this list. The radial is going to be really the back of the forearm. The musculocutaneous is going to be up as well as your biceps. See how the axillary nerve actually curves around here on your shoulder? That's where you're going to find it. The median nerve. The median nerve is named median nerve. If we looked at our skeleton, we have our 2 bones, our radius and our ulna, but the 2 forearm bones, the median's actually between the 2. So that's why it got its name, for being between those 2 bones. And what it's going to serve is your palm, your fingers. That's going to be your thumb, index finger, middle finger, and part of your ring finger. So we're going to go hands, palm, fingers. The ulnar nerve is next. The ulnar nerve is also known as your funny bone. When you hit your funny bone, so if you were to feel the point of your shoulder, you're going to feel the point of your elbow and just move medial, and you have this other bony point. So the 2 here. If you then push right in between the two, you're gonna feel your ulnar nerve just goes right on the bone, right above the bone right there. So that's why if you hit it at the edge of a table, you are just hitting the ulnar nerve and it hurts like the dickens. And it's actually sensory information going to your brain as if what part of your body is hurting? It's gonna be your forearm down to your pinky and part of your ring finger. That whole area, tell your brain it says it's on fire when you hit your ulnar nerve or your funny bone. Really, all you did was when you hit those axons, you actually depolarized the sensory part that actually went to your brain to say that there's damage here, when really it wasn't. You just created an action potential from those sensory. The areas it's going to be your pinky and your ring finger. The radial nerve is named because it goes along the radius of your forearm, but it really has branches very high up all around your upper arm as well as the lower arm or forearm. So the easiest way to think of the radial nerve is mostly posterior forearm. So if you're going to cause extension of your hand, that means moving them back. That's going to be your radial nerve doing that. Your musculocutaneous nerve is going to go to your anterior lateral forearm and your biceps brachii. So it's going here to your anterior forearm. So it's the opposite of your ulnar nerve. So as you come down, you have your funny bone. Ulnar nerve is going to show to be your medial forearm to your pinky. Your musculocutaneous nerve is going to be your lateral forearm, but most importantly, the main one that I'd probably ask you about here, just because it gets confusing with the median nerve, is going to be your biceps. A branch of it comes off to your biceps brachii. So this is the summary slide of this. The brachial plexus has C5 to T1. So the axillary nerve is your shoulder, lift your arm up. Radial nerve is going to be on the back of your arm, and it's going to be extension. That's kind of moving everything back. Then we have ulnar nerve, which is going to be your medial part of your forearm. Think of your pinky and ring finger, where the funny bone goes. Median nerve is going to be flexor of the hand, like bringing your flexion of your wrists up this way, moving your thumb. The musculocutaneous nerve is going to be flexion of the forearm, like your biceps. There is the lumbar plexus. Okay, so the lumbar plexus, what's the spinal nerves? T12 to L4. And the ones you should know, there are 3 listed. The one I'd probably ask you about is just the femoral nerve. But I want to let you know there's the femoral nerve here, femoral nerve, and it's going to your anterior thigh, also known as the muscle there is your quadriceps. So it actually will kick your leg out. The most important part here is that it's going to your anterior, the front of your thigh. We have a different one that's going to go to the back of your thigh. But it's going to your front of your thigh. It's going to the front part of your thigh. But notice on the list here, it also is genital femoral. So it's going to your genital region as well. And it's going to the obturator nerve. The obturator nerve, notice the skeletal system. See these holes right here at the bottom of your pelvis? It's known as the obturator foramen. So actually one of the branches from the lumbar plexus comes through here. So it's actually going to the middle of your thighs. So the lumbar plexus is going to send nerves to your anterior thigh, to your middle thigh, and to your genitals. So that's kind of its territory, if you want to think of where it's going. We can see in yellow here, this is the lumbar plexus, where it's coming from and has lots of different branches. So the main one I want you to know is the femoral nerve serves the anterior thigh. But know that the middle of your legs and the genitals are also coming from the lumbar area. The sacral plexus is L4 to S4, and we're going to have the pudendal nerve, which also goes to the genitals and sphincter muscles. Then we have the biggie. The big nerve is our sciatic nerve. Our sciatic nerve is so big, it's more like a root that's going to branch off. So the sciatic nerve is going to go down how thick it is there. It's as big as your finger. It's huge as far as nerves go. It's a really quite large one. It's going to be, in this picture, we see the sciatic nerve coming down the whole back of the leg. And then notice on the back side of the knee, sort of expanded view, we can see that it divides into what's known as peroneal or fibular. It's the same nerve. It just means going out to the side, outside of the leg, to the side. And then you have the tibial nerve, which is going to go continue on the back side of your shin. So the sciatic nerve here, we know that it's going to go down the back of the thigh. So we will say posterior thigh. And then it's going to divide into the lower. So if we have the tibial, we're going to say posterior lower leg. And then we have our peroneal. That is starting to lose favor. It's starting to become more of a fibular nerve, which will be lateral leg, lateral lower leg. So on this image, we can see the sciatic nerve coming down off of the sciatic region. So this is all sciatic nerve. So if we say the whole back of the leg, opposite of the femoral, right? So the sciatic nerve is going to be the back of the thigh. And then we're going to divide it into the lateral side of the leg. I'm going to just here, or just the other part of our lower tibial. So it just turns into two different branches from the point of the knee. So you should know the number of spinal nerves: 8 cervical, 12 thoracic, 5 lumbar, 5 sacral. What neurons make up a spinal nerve? You have motor and sensory, also known as efferent, which would match motor, and afferent, which matches sensory. You have the connective tissue layers around the nerves. Who could tell me the name of the connective tissue around a single neuron? Endoneurium. Who knows of a tissue around a group of neurons? The perineurium. And who can tell me the name of the connective tissue around a whole entire nerve? It would be epineurium. Dermatomes are strips of skin that is innervated by specific sensory neurons that match up with those nerves that are coming, spinal nerves that are coming off the spinal cord. You should know the name of the spinal nerves that make up each plexus. So for instance, C1 to C5 make up the cervical plexus. C5 to T1 makes the brachial plexus. T12 to L4 makes up the lumbar plexus, and the L4 to S4 makes up the sacral plexus. So that's what spinal nerves make up each plexus. And then the major nerves from each plexus. That means for the sciatic, so the sacral would be the sciatic and the peroneal and the tibial. For the lumbar would be the femoral. For the cervical, it would be the phrenic. For the brachial plexus, it's those 5. So those would be the ones that are coming from the plexus but going out to the rest of the body. So we're going to do the spinal reflexes. What do you guys know about a reflex? Who can give me an example of a reflex?
When you go to the doctor, when you're little,
On the knee, the tapping of the knee, that's right. So if you're sitting there, let me pull up a chair and I'll whack my knee. So if you're gonna sit, okay, I'm gonna sit here and I got let's go lower, got this knee and I got this, use this marker to pretend whack myself, and they usually have your legs dangling nice and loose off the table. So your quadriceps are like nice and loose. And then you end up getting whacked, by that hammer, rubber hammer, and then your lower leg just swings out, like it's kind of like, well, I didn't even make it do it. It just did it on its own, So what's happening in that reflex arc, so I have on the board here, is when the tap comes in, so you have the end of this, the hammer, literally hitting the ligament from the end of your kneecap, your patella, to your shin bone, right? So it really pushes in there. And so it's affecting your quadriceps muscle. So it's actually sending a sensation from your quadriceps muscle. A sensory nerve is coming to the back of your spinal cord going, hey, we just got whacked at the patellar tendon and it made a stretch of the muscle actually, because when you push down here, it kind of pulls on the muscle part. You guys with me on that? So that sensory information is coming around to the back part of your spinal cord through those dorsal roots into the spinal cord, and before your brain even gets the signal, the motor side goes right back out to the quadriceps to say, well, we better contract. And that's why your leg is out pretty much the same time your brain gets a sensation that you got whacked. What a reflex is, by definition, is when you have a sensory impulse from the body coming back to the spinal cord and a motor response coming out that did not require processing in your brain. It just went in the spinal cord and immediately went out. That's what a reflex is. So the wiring of a reflex is, if we were to say, here's a receptor, maybe we have, and we'll say dendrites of a neuron here, kind of a receptor. Then we have sensory axon, also known as afferent. Remember, it's going back here. So we have our sensory axon. It's going to come in to our spinal cord. We have our spinal cord here. We have that pointy posterior side. We have a rounded anterior side. So we have our sensory neuron axon. So if you got whacked by your knee, has the stretch or whatever the impulse is going to be, we're going to talk about 3 different types of reflexes. The stretch one, the knee one, is just one. So the receptor is picking up different things in different types of reflexes. Brings the information back into the spinal cord. It's going to connect to a little interneuron in here. And then it's going to connect to this green guy, which is going to be our motor axon, going out to the muscle. And in the case of that knee whacking one, it's going to contract. So what the reflex arc means is you have a sensory impulse coming in, connects right over, right to a motor impulse right out. So if you've had a spinal cord injury that if you were to whack someone's knee and their leg would still fly out, but maybe they had a spinal cord injury that their brain didn't get the information and they can't move their legs. So they can't move their legs. It didn't come from the brain for voluntary movement, but within the spinal cord at that part is still working. Does that make sense? And even though from the reflex, because it originated from here all the way out. So a lot of times someone gets a spinal cord injury, it's about not having voluntary control because the impulse isn't making it from the brain because somewhere along the line there was an injury. But if you do a reflex, you can still see, oh, in that particular area, the spinal cord is actually still intact, but we can't get the impulse to or from the brain itself. So that's what's important for a neurologist to test these reflexes, because it's really testing the pathway. Hey, are our sensory neurons working? Are the muscle neurons, motor neurons working to the muscles? Okay, you know, so it's helping to identify the routing system is indeed still intact. So the steps of a neural reflex is you're going to have a receptor, gets a stimulus, whatever it's going to be. It's going to go to the sensory neuron. It's going to go to the spinal cord here. Then it's going to go to the motor neuron, out, and then to whatever response is happening. So the term for a reflex is involuntary response to a stimulus. And the key here is the word involuntary. The spinal reflexes that you're going to need to know, there are 3 main ones. The last 2 are sort of combined together. The stretch reflex, which is what we just talked about. We'll go into more detail. The Golgi tendon reflex and the flexor or withdrawal reflex, as well as the crossed extensor. The stretch reflex, the stimulus, you can see someone getting whacked here at the point of the patellar tendon. When you whack someone at that patellar tendon, what happens is the muscle pulls, it's sort of being pulled down. And it's not like if you're sitting there in your chair and you could push all day long, and you're like, I'm pushing, nothing happens. It is how quick it happens. So it's the quickness, the rapidness of the whack rather than the hardness of it. Does that make sense? So it's a rapid stretch. So your muscle feels this rapid elongation because of the hammer hitting this. That's because there's these weird little spindles located in the belly of every muscle, and they detect rapid stretch. So they're the ones that's going to send this back. And it detects, I'm going to emphasize rapid or fast. That's why I put it in capitals, stretch of a muscle. You can do it to any muscle. It's just easier to do it to your knee. If you were to, you could feel tendons in your arm. So if you were to have someone have their arm, they have to start with in a really relaxed state, really relaxed arm. And that's why those reflex hammers are wide at one end and they're triangular, so they're narrow. So you can go to specific smaller tendons. You can have someone really relaxed with their arm laying there. And if you whack one of the tendons here, their arm will do this. Or you could do it to the forearm here. If you hit it in the right spot, their hand will jerk. So you can do it for every muscle. It's the trick is really finding the tendon and isolating it and hitting it as precisely and quickly as possible. So again, the muscle has a rapid stretch, sends the sensory nerve, comes right back up the motor side, and its response is, and the effect of it is going to be muscle contraction. So in summary, for a stretch reflex, the stimulus is rapid stretch of a muscle. The effect is contraction of that same muscle. The next type of reflex is known as the Golgi tendon reflex. It's going to have receptors in joints, in tendons, where muscle is attaching to the bone. When a muscle is contracting so hard that it actually is at risk of tearing that tendon away or breaking the bone, the force is being so great in this area of pulling onto this bone that you're at risk of personal damage by your own muscle contraction. That is the sensory stimulus that comes back and it immediately goes out to the muscle and it causes that muscle to just relax. You just just all of a sudden stop contracting. So it will cause relaxation or stopping of the contraction. So people that are like professional arm wrestlers that have just these huge arms and they're arm wrestling each other, their muscles in their arms are so powerful that they can actually break their own bone by the contraction of it. The Golgi tendon reflex is a reflex that when tendons are experiencing excessive force, I'm going to put in parentheses, enough to do damage, tear a tendon, tear a ligament, break bone. The stimulus is going to come back to the spinal cord and just make it stop contracting. It just relaxes it and you stop the impulse from arriving at that muscle. The last reflex, it sort of comes in a set, is known as the withdrawal reflex. The withdrawal reflex means that you touch something, it was going to do damage to you, so you pulled your arm away. Or you pulled, for instance, if you were to put your hand on a hot pan and you feel that it's hot, you don't wait for your brain to go, wow, that's really hot, I should move my hand. So you touch something hot, your arm is already pulled back before you can even think of it. So again, the reflexive action. Your brain still gets the info of what was going on, but you've already pulled your hand back to save yourself. That's a withdrawal reflex. So it's on the same side. You're moving, it's also known as a flexor because you're flexing the muscle to come back, but it's known as the withdrawal, probably more commonly. You have the stimulus for that would be some sort of damage like excessive heat is one example. Touching a needle, pain, we'll just say pain. It could be on your foot. If you stepped on a needle, or if you're in my house and you stepped on a Lego piece, you know, you're like step on something and then you immediately need to pull your foot away. That's going to be your withdrawal reflex. So some sort of pain is going to come into your spinal cord and then coming out the muscle is going to, in that area, is going to contract to withdraw the limb. We'll just say hand or foot. It's usually the end of the limb that's experiencing the pain, but it's just going to take it away from the source of the pain or damage. So that's known as the withdrawal or flexor. So this schematic here, you can see someone touches a hot pan, sensory impulse comes on the sensory side, goes right out to the flexor muscle to move away, but it does something kind of cool. Not only is it contracting a muscle to move your arm away, at the same time it tells the opposing muscle, it actually inactivates it. So it makes it easier for you to pull away. So I told you this is a 2-for-1. We have the withdrawal reflex, and it's kind of combined with your crossed extender. If you have the hand one, for instance, this, you touch something hot with your left hand, it goes into the spinal cord, and it comes out to your left biceps brachii and tells it to pull back. That's known as ipsilateral. It's the same side. Now, contralateral, which is in red here, means you're going to go to the opposite side. You're going to need that in the Lego situation. If you are going to go and step on a Lego, the pain is coming from your left foot, going up to the spinal cord, and it's going to want to go out to your left leg to lift it. But at the same time, you also have to go to the right leg to tell you to hold yourself up. So you need to also contract the right leg while you're lifting the leg. So that type of reflex actually is more complex because it's using more parts of the spinal cord. Not only is it coming in on the one side and going out on that same exact side to lift the leg up, but it's going across the gray commissure to the right side of the spinal cord to tell your opposite leg, you better brace yourselves because we have to lift. And so it's actually testing both sides of the spinal cord in that case to make sure that the spinal cord doesn't have any damage or lesions inside. So that's like a flexor reflex, and then now that the cross extensor portion is going to straighten or do the other leg. The last reflex, I don't have a test question on it though. I have a test question on the stretch reflex, on the Golgi tendon, and the withdrawal reflex. Those are the three, and crossed extensor. The Babinski I'm going to tell you about, but I don't have a test question on it. If you were to swipe, this is also why the reflex hammers are shaped how they are, swipe the bottom of the foot, you actually, like it feels weird, so your foot will contract down like in the normal way for this A, but if you have some nerve damage, you have a weird response, and actually your foot will flare out. Now, on little kids, less than 2 years old, that's normally what happens, but it's because their legs aren't quite done myelinating. They actually have some neurological development they haven't gotten to yet. So it's normal for them to turn out like this or extend out. So for the spinal reflexes, do you know the different reflexes that there are? The stretch reflex, the Golgi tendon apparatus, the Golgi tendon reflex, and the withdrawal associated with the crossed extensor reflex. For each reflex, you should know the stimulus that we went through. For the stretch reflex, or the is stretch the muscle, and then the effect, contract that muscle. For withdrawal, pain, contract to pull muscle away. For the Golgi tendon reflex is excessive force enough to cause damage, and then the reaction is relax the muscle. So it's kind of an opposite deal in that. And know the function of each reflex. So the stretch reflex prevents muscle from overstretching. The Golgi tendon is going to prevent damage by excessive force. And the withdrawal is just removing your hand from a damaging source, whether it's a heat source or a sharp knife or whatever you're touching. The last section here is known as sensory receptors. Nociceptors are going to be pain receptors. Thermoreceptors are to detect temperature. Chemoreceptors are going to detect some sort of chemical, a molecule. So that might be like oxygen or carbon dioxide, or it could be other things. So any type of chemical. Mechanoreceptors are more mechanical, and they're the ones that we're going to spend a little bit more time on, or just going to detail. You either have the tactile, which means touch. So tactile is some sort of sensation, more touch. Baroreceptors are going to detect pressure. So these are actually found in your arteries, and we learn about these in 202. Proprioceptors, we just learned about those. The muscle spindles is the stretch. The Golgi tendon is the excessive force. Those just are more about where you are in space. So those are some examples there. The touch and pressure specifically, we have fine touch, like really light, and then we have the deep ones. But we already talked about these, so this here is a bit of a review. Who can remember when we did skin, which was the fine light touch, and then what was the deep pressure, and then which was the twisting one? You guys, I'll tell you how I try to remember. I don't know. The fine touch, remember really fine. I always remember they're the ones that start with the M. Merkel's and Meissner's, because their nerve endings are really close at the bottom of the epidermis. And then remember Pacinian. You guys know what Pac-Man is, right? It's not just me, old days that grew up in, like, when I was a kid in the 80s or something. I just think Pacinians, they're just your deep pressure, like you're just squeezing somebody, like a Pac-Man. And then Raffini's, I think someone's playing really rough, and so they're twisting. You know, that's kind of nasty when you're wrestling someone, they're twisting. So that's more of a distortion, which means twisting. So it's sort of how I categorize them in my mind. Fine touch are the M's. Deep pressure is the Pacinian, that's the Pac-Man, and the twisting is the Raffini. Baroreceptors to check pressure, that's in your arteries. Proprioceptors is more your body, like joints and stuff, and we already did these. Muscle spindles is your stretch. Golgi tendon is the one that's over force. You should know what are the 5 sensory receptors. Receptors, nociceptors for pain, thermoreceptors for temperature, chemoreceptors for chemical, and mechanical receptors for anything that's touch or distortion of sort of physically pushing, whether it's pressure or joint movement. The classes of the touch version, mechanoreceptors, you should know fine touch. I think within the classes are the pressure as well as the proprioception, where you are in space. The touch and pressure receptors, you should know the 2 M's, Meissner's and Merkel's are fine touch. Pacinian is deep pressure. Raffini is twisting or distorting. Proprioceptors just have to do with where your joints are in space, and stretch, the 2 reflexes won't stretch, and Golgi tendon. And baroreceptors detect pressure like in arteries. Most of these, so this is what we can choose to do. The cranial nerves are, there are 12 cranial nerves. You need to know their names. You need to know their Roman numeral. So whether they are number 1, 2, 3, but in the Roman numeral form. And their action or something that's wrong. So we'll say pathology. Not for, but something that it does. So sometimes we'll do a pathology. So we're just going to go through them because they're easier probably later for you to review on your own. This is the 12 cranial nerves. You can see their Roman numerals. If anybody needs help with doing Roman numerals, let me know. One way to remember them is look at the first letter. So we can go ooh, 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 okay? 2, so we have 2, touch and feel, very good, velvet, ah. That's like the old school one. There's probably way better ones out there. So this is actually from my book in the early 90s right here. The first cranial nerve is olfactory, that's smell. Your second cranial nerve is to your eyes, your vision. So the smell receptors are right there in the top of your nasal cavity. And number 2 is your eyeballs, coming from your eyeballs going to your brain. So it's cranial nerve number 2 coming into your brain. 3, 4, and 6. 5 is on its own slide. But 3, 4, and 6 control your eyeball. So that's why they're grouped together. Oculomotor is actually going to move, it actually moves your eye medially, like it brings your eye in, like if we're talking about this one, brings it in. So that's oculomotor. See the very bottom one, abducens, it brings your eye out. So if you have an eyeball here and your eyeball is like turning inward towards your nose, that's the oculomotor doing it. If your eyeball and you're looking off to the side over here, that's the abducens nerve doing it. So when you go to the eye doctor and they tell you and they're asking you to follow your finger, hey, I want you to follow my finger side to side, they're testing your oculomotor and your abducens nerve. Now down and over, like if you're sitting there and your face is looking at your own test and you're trying to read your neighbor's test, that's the trochlear nerve doing that. But when your eye doctor is doing the side to side, he's measuring the oculomotor or the abducens. But when he's like, okay, follow down and over, and your head, you're supposed to like be like looking straight forward, then that's testing your trochlear nerve. So down and out is trochlear. Moving your eye laterally is going to be abducens. The oculomotor that brings your eye medially also does a couple other things. It goes to your eyelid. So if someone has damage to this number 3 cranial nerves, they're going to get like a droopy eyelid. And so then it also affects their pupil. So if someone has a lesion in their brain or some sort of damage that on one side, not only does their pupil not change, but they have droopy eyelid and they can't move their eye medially, you're like, we got damage to the oculomotor nerve. We know exactly where that is. You can locate it in the brain where some sort of damage would be. So the abducens, because it brings your eye out, if that nerve is damaged, a person will be cross-eyed. You know, I grew up on a ranch, so I think of this in terms of if you're driving a wagon of horses, you have like a rein on one side, a rein on the other side to keep them going straight. So you have them kind of like, you're not pulling on them to make them stop, but you have them enough tension that you can feel your horses. You have your oculomotor on the one side, the abducens, and you need even pressure on both of them. If all of a sudden the abducens wasn't working, the other one becomes more prominent. So that's why even though the abducens is meant to move your eye outward, when it's not working, your eye then would pull and do the opposite. So if I were to ask you on a test, if something's wrong with somebody and they're cross-eyed, what is their problem? What is their pathology? And that would be the abducens is having a problem. Number 5, the one that I just skipped, that I didn't put in that group, trigeminal. This is the one that your dentist is concerned with. So the trigeminal has 3 branches. 2 of those 3 are going to deal with teeth. The maxillary branch and mandible. You don't have to know the branches. Just know the trigeminal, they are going to go to, they are ultimately what the roots of your nerve roots from your teeth are going to go to. We also have an ophthalmic branch that's going up near the eye. So the trigeminal has 3 branches that comes across your face. Number 7 is your facial nerve. So it's just going to the muscles of your face, facial expressions. Vestibulocochlear, that's number 8. It is going to your inner ear. So there's 2 parts to it. You don't have to know the parts individually because we'll learn about those in the next unit. But the vestibulocochlear cranial nerve number 8 is all about your balance. That's your, and cochlear, your hearing. So it's your inner ear, which is where our balance is and our hearing is located together. So the glossopharyngeal, which is nerve number 9, that one is going to the back of your tongue. So it's actually helping you swallow. You know, when food goes to the back of your mouth and then you like just automatically swallows, it's also going to some of your salivary glands. But you want to think of that as more of your swallowing. Number 10 is known as the wanderer, the vagus nerve. This one's probably one of the more important ones that we're going to deal with in 202 because this one's the only one that leaves kind of like your head area. This one, cranial nerve number 10, that's why it's known as the wanderer or the vagus nerve, because it goes to your heart, it goes to your gut. It's controlling a lot of your autonomic or those automatic things. Remember I said you don't tell your stomach to start secreting acid or move food along. It's the vagus nerve that's going to take care of business here. So it's actually controlling a whole part of your pharynx, diaphragm, your visceral organs. So it's going more to your body, to your heart. It's slowing your heart down in a good way. So that's vagus nerve number 10. Number 11, accessory nerves. It's going to your some of your muscles as well as your pharynx. So I like to think of the accessory nerve since it's coming to your trapezius muscles, and we haven't learned specific muscles, but they're right here off your neck. So it's the nerve that's going to help you shrug. It just does this. So if you're going to see a neurologist, they may put a hand on your shoulder and say, lift up and push against my hand. And then they'll do it to your other shoulder, lift up and push against my hand. And you do that, and they want to see, is it even? One, can you do it? Two, is one side weaker than the other side at it? You don't have, so that's what's going on. So think of that as the shoulder shrugging. That's number 11. And the very last one is the hypoglossal, meaning below the tongue, and it's more of a motor. We already had a glossopharyngeal, that's your swallowing, but this one is just muscles of the tongue. And so I like to think of my niece with this one. She was kind of a bratty kid. So the hypoglossal would be the one, because she liked to walk around and go, and she'd stick her tongue out at everybody. Anyway, so that's the nerve for my niece, but that's hypoglossal. So if you want to think of cranial nerve number 12 as muscles protruding and sticking your tongue out, because it's more of a motor function. So I try to give you more of like just a quick brief summary, and I believe here is a cranial nerve summary chart. It has the Roman numerals, the name of the nerve, kind of its action, and sort of something that would be wrong or something pathological or clinically with it.
Do they all have a pathology? Okay, no, they don't.
A test question, or shall I say the test question that you will have on the test, is really a chart. And I will say it's going to be 24 points. You have, tell me the cranial nerves, the number of the cranial nerve, tell me the name, and tell me what it does. There you go. That's your practical exam. And then there'll be a few questions on the scantron portion of this exam that might be like, which nerve is damaged if you can't stick your tongue out? And you'd be like, that'd be cranial nerve number 12, or you'd have to know it's named hypoglossal, or what nerve is damaged if you're cross-eyed? Oh, that would be abducens. Or which nerve is damaged if you can't hear? Number 8, vestibulocochlear. Or which nerve is the one controlling you cheating on your test, looking down to your neighbor, down and out, vision, trochlear nerve. Yeah, so the scantron part will have those type of questions, but your practical is pretty much this chart, number, name, action. That's what that part is.